Well, why don't we start?
Okay.
I really appreciate everybody joining. My name is Chris Blosser. I'm a transplant nephrologist and have a unique interest in the care of people who have cancers before and after organ transplant. And so, in order for us to continue to learn together, I've established a research center named the Center for Innovations in Cancer and Transplant. And with that, also a clinic, the Cancer and Organ Transplant Clinic at the Fred Hutch. I have appointments at the University of Washington and the Fred Hutch Cancer Center. And I'm really happy that you've joined us for our first Life Lessons, a quarterly webinar where we're intending to bring together patients, providers, and researchers to learn about and then implement that knowledge in ways to help the future. And our first Life Lessons is intentionally going to look at where we've come from and where we're going. And so we want to have a conversation today on the history and the impact of our research center and our clinic. I've established some objectives that hopefully can guide us through not only today, but future webinars. And those include sharing the evidence-based insights on advancements in cancer and transplant care to empower patients, families, and healthcare professionals, highlight personal, clinical, and research experiences that foster resilience, inform decision-making, and improve quality of life, and promote collaboration and innovation in research by connecting participants and resources for ongoing research and then integrating that research back into clinical care. So to start, I want to invite Austin Cook, who's a patient from the clinic, to introduce his experience in life related to transplant and cancer.
Funny.
So I appreciate everybody joining us. And as we kind of move into the next chapter of this, if you wouldn't mind muting yourself and listening to Austin, that would be great. Austin, I'll stop sharing and let you guide our conversation. Thank you.
Okay. Well, I'll give you a brief, history, not birth to death, but of what I went through as far as with diabetes. So I got diabetes in 1976 at the age of 9. Um, and at that point, there wasn't a lot of research done or a lot of knowledge. I mean, they sent me home with a jar of sticks to pee on, and I would pee on a stick, and it would be brown, and I'd write down 4+. And once a year or once every 6 months, I go to the doctor, and he'd go, "Yeah, take a couple more units of insulin." I said, "Okay." So I would, and this went on for most of my young life. We had no idea about carbohydrates. They said don't eat sugar, so I didn't eat candy bars, but I pasta like I was going out of style, spaghetti, pizza, the whole nine, and things that now I know better, will raise my blood sugar exponentially. So, um, got to be a teenager. They came out with the first blood glucose meter, and it was the size of a brick. It was large, and I you basically you jabbed your finger, you put a blood on a stick, pressed a button, waited 1 minute, it would beep, you'd wipe the blood off the stick, put it in the machine, press a button, wait another minute. So it was a 2-minute process, which in the grand scheme of things is not much, but when you're a teenager and you got other things to do, you know, doing that was a pain in the butt. So, but I went to the doctor, and it wasn't until, and my wife's in the background, that's my wife, Michelle. I think we were married at the time, and I started having eye issues. So it turns out I had retinopathy in both eyes. So I had 2 laser surgeries in my left eye and 3 in my right eye. And it kind of set me in a place where I figured I better start taking care of my diabetes. So started seeing a nephrologist and started getting a little bit better control. But even with all that, my kidneys started failing in my 40s. And so my doctor recommended I get a fistula for the inevitable dialysis that was going to come up. So I got my first fistula, and they put the fistula in your left arm, and then they had they attached to a vein down here. Then they brought the vein up to the top, and I still kept chugging along. So 6 months later, the thing wasn't pulsing anymore, and didn't think much of it. Just okay, it just clotted off from non-use. That's what I thought. The doctor kind of thought. So we did a second surgery, And when I got home that night, my arm swelled up with like a baseball size, you know, clot on it. It turns out, after going to the hospital and being in there for a week, that I have factor V Leiden with lupus antigens, which kind of throws a curveball and everything as far as even the transplant went. And when it came to the transplant, they had to find the perfect organs with no kinks, no nothing that could clot off, things of this nature. Um,
Meron Cecil.
oh. Anyway, so he also referred me to the UW Transplant Center, which I started going there, started meeting with doctors, talking about what was on the table, what was going to be, um, you know, what was going to happen as far as the transplant went. I had to go to a hematologist, a local hematologist, because the blood clotting disorder and get cleared by them. All the things that go through transplant. Went through all those things. Um, my GFR finally dropped down to 9, and that's when I went on dialysis, and that was in 2015. That lasted about a year until I got the call. I got many calls over the next year, but I was always, second in line, or the organs weren't good enough, etc. And so we were at Valentine's Day party, and I got a call from the UW that said, "We got it. We got you. Donor be here tomorrow morning at 8." So went home, got ready, went on that Sunday, and Monday, February 15th of 2016, I had my transplant. Um, Spent 16 days in the hospital, and then went home. I was home for 3 days, and I started running really high fever. Went back in the hospital. I was in there for almost 3 more weeks. Um, and when they finally took my second drain out the next day, the fever was gone. So pretty sure that was the culprit. They tested everything. Everything that went in and out of my body was tested to make sure that it wasn't part of the infection. So I one thing I remember about being in the hospital was the pharmacist. In the first 16 days, the pharmacist comes down to your room and he explains to you what's involved with taking all these medications. And he did this analogy, which has stuck with me to this day. He talked about if you have a fence and you miss a day of taking medication, it's like throwing a baseball and putting a hole in the fence. Okay, one hole, no big deal. You start missing more days, the hole starts getting bigger. Pretty soon the hole's so big, then now your body's going to attack the organs. So it stuck with me. I think in the 10 years since my transplant, I might have missed 3 doses. I mean, I pretty much don't miss doses. So that stuck with me. But when I finally got well well enough to go home, I got home and I went home with a cough. I started coughing and found out, gave myself a surgical hernia. So everywhere they cut me, which is from the upper chest down to my belly, below my belly button for the transplant, all that had come loose. And so I had to wait another year to get a surgery to correct I had a hernia surgery. So it was an experience. Um, Actually went really well for the first quite a few years. Then in July 2020, I had a couple of what I thought were zits, one on the back of my head and one on the side of my head. And so I go to this local doctor at Cascade Skin, this Dr. Hirota, and he checked it out and he said, yep, looks like skin cancer. And I was like, say what? And so he said, we're going to take a biopsy and I'll let you know. So a week later, he calls and said, yep, you got cancer. Came back basal cell carcinoma and squamous cell carcinoma. So he suggested we do this ED&C, which I had done, which is basically they cut the cancer out and cauterize it. They did that 3 times on each spot. And the one in the back of my head never came back. The one on the side of my head, within a year, I noticed it had a new growth on that same spot. So I went back to the same doctor and he said, well, looks like a pilar cyst. I said, yeah? He's like, yep, just pilar cyst, no big deal. Okay. So I had a follow-up 2 months later with him to do my full body scan. And the cyst had grown. I said, hey, can you do something about this pilar cyst? Can you take it off? He goes, that's not a pilar cyst. It looks like Merkel cell carcinoma. And so I'm, Googling Merkel cell. And I said, well, what does that mean? He goes, well, you have you have a, what do you say, 60% chance of recovering from it. I said, well, I had 100% before I came in the door. I didn't even know I had this, you know? So long story short, I got my first Mohs surgery in January of 2022, and that's when they took care of that, pilar cyst, which wasn't a pilar cyst. Um, so I had that surgery. Then a year later, I had another spot show up, so I did a biopsy, and in February 2023, I had a Mohs surgery with Dr. Maureen Mooney, who is fantastic. She is the best, and if it wasn't for her, I would not never been referred to Fred Hutch, and I don't know where I'd be today. That being said, we did this surgery, um, and then later that year in August, I had another biopsy and had another Mohs surgery done. And while I had the Mohs surgery done, I asked Dr. Mooney if she would do a biopsy of my left eyelid because I had a spot down there. She did, and it came back cancerous. Um, but she said that I needed to go see because that came back. We had cancer again. She directed me to Dr. Sorensen in Tacoma, who's he's a surgeon. Um, so I went to him. Dr. Mooney's great. She actually called him the day my biopsy was August 31st, and of course right before Labor Day. They called me on Friday. Dr. Sorensen's office said, "Can you come in on Tuesday?" Went on Tuesday, and I went there because I had a hard spot in one of my lymph nodes in the back, and it wasn't going away. So when I went there, he goes, "Yep, we got to remove several of these spots, several of your lymph nodes." He said, "Do you want surgery on September 8th or September 22nd?" I said, uh, I guess the 8th. So he did a biopsy and it came back as positive, which he pretty much he assumed it was going to. So he did a surgery in December of that year. No, 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 he did that surgery in September, and that it's a huge spot. They did a a biopsy off my leg, not biopsy, I'm sorry, skin graft on my leg, put on my head, and it looked hideous. And it still is not great looking, but it's gotten better over time. Um, but at the same time, Dr. Mooney called me and said, after I saw Dr. Sorensen, when they got the biopsy results back, she goes, you've had too many, you have poorly differentiated squamous cell, not Merkel cell, basal cell, squamous cell. I'm going to send you to Fred Hutch because something's not very good. And so she made a call. They called me back in 2 days, had an appointment with Dr. Hall in December 2023. He suggested a PET scan. So we got that done before the end of the month. And then I went back in January 24 and I met with Dr. Hall and Dr. Blosser. And it was a good meeting. I remember Dr. Blosser asking me, what do you want? I said, well, I want to live. He goes, okay, well, I'm hearing you want to live. I said, and I want my organs. And so I know I was asking for a lot, but we discussed different plans. And because the PET scan came back with a bunch more cancer in my everywhere on my left side of my head and my lymph nodes, I was referred to Dr. Marciano, who in February of 2024 did a radical neck dissection. Basically, they cut out all the lymph nodes. About a half hour into the surgery, they called my wife and said, "Hey, Dr. Marciano didn't say, hey, we're in the surgery room, but he has cancer wrapped around his facial nerve. Do I have permission to try and take it off? He could be paralyzed on his left side from that." And my wife's like, "Yeah, we need to get rid of the cancer." So we did. And she told me before the surgery, my worst case scenario would be that we'd have to do a lot of, a lot of taking out of lymph nodes and whatnot, and maybe even have to do a pec flap where they take part of your pec and they put it up in your neck. Well, maybe in worst case scenario guy for the most of my life. Sure enough, I woke up, I had a pec flap. I had all this, staples and stitches and whatnot. But that she also suggested I do 6 weeks of radiation. So I started radiation that year in March, and I did head and neck radiation. It ended up being 8 weeks because I had a second spot show up during the radiation. So 8 weeks of head and neck radiation. That was probably the worst part of this whole experience. I couldn't swallow. Um, Everything tasted bad. My skin started peeling off my neck, literally peeling off. But I got through it, and fast forward to July. Um, I woke up, my face was all messed up, and it turns out I had Bell's palsy, which I still have, even though it's been a year and a half. I was hoping it'd go away by now, but it hasn't. So I had Bell's palsy. Then I had a port placed in on September 24th so I could start chemo. I did 3 rounds of chemo with carboplatin and Taxol, and that was basically once every 3 weeks from September 23rd through November 12th. And I realized that I had double vision, so or 6 nerve palsy is what it's called. So I went to Harborview. They did a bunch of scans, make sure it wasn't anything bleeding or I was going to go blind. So that 6 nerve palsy, that double vision lasted almost a year as far as having a patch on or just, I got through it, but I couldn't drive, which was kind of my downfall. I mean, I've always been the errand guy, I do the shopping, the cooking, and things like this. My wife does it too. She cleans it. It's a mutual thing, but I've always been the guy, to go do all the errands, and I couldn't do it for almost a year. So it was nice. About 3 months ago, I started driving again, and it's been such a relief. It's a kind of you don't realize how much you depend on it until you're not, until you don't have it. But with my port that I placed on September 24th, it became infected. And so a month later, I was in the hospital for a week while they took it out, started me on a high dose of different antibiotics, put a PICC line in, came home with the PICC line. My wife had to give me antibiotics 3 times a day, 6 hours apart, I think it was, or 8 hours apart. Yeah. So we did that, used the PICC line for the next phase, which was it was let's see, monoclonal antibodies. So I started that in December. That basically I stopped the chemo because of the effect it had on me with not only the double vision but the Bell's palsy, and so we stopped that. Went on to monoclonal antibodies, so cetuximab. I did that for 3 months, so December of 24 to March of 25. We had a PET scan, and I was getting worse. It wasn't getting better. So the third and final thing, and we discussed this when I first went in, what the options were. So it was chemotherapy, it was monoclonal antibodies, and last but not least, immunotherapy. I was scared of immunotherapy because what immunotherapy does, and you probably all know this, it boosts your immune system, to the max. And so now my the therapy I've been taking for 9 years, immunotherapy, not immunotherapy. Babe, help me. What?
Immunosuppression, Austin?
Immunosuppression. Thank you, Dr. Blosser. Immunosuppression, is keeping all this stuff suppressed so that nothing attacks my organs. Immunotherapy, unfortunately, it did what it's supposed to do. It fought the cancer, but it also put me into a rejection, of my organs. So when I went into, I only did 2 bouts of it. I did one on April 15th this year and May 14th. Meanwhile, when I was in the hospital, they gave me huge boosts of steroids. I mean, big batch. And my numbers, believe it or not, started getting better. I say believe it or not because most people didn't believe it was going to happen, doctors included. And so since then, at that point, I was at my weakest. I was coming home. I was using a rolling walker downstairs and upstairs. So the only time I would be without my walker was when I was going up the stairs, and it was a battle just to go up 16 steps. And I'd be winded. I took a couple of tumbles getting to the top of the stairs. I mean, it really had an effect on me, making it very weak. But since then, the numbers have gotten better and better. My CT DNA test, which when I first started this journey was a 10, and then it went down to a 5. That's the amount of DNA, cancer DNA in your blood, from what I understand. And so from 10 to 5, went through all this radiation. It went up a little bit. I was very discouraged. And then when I was in the hospital with this, it really climbed over last year into 200s, which is very high. It's currently at 0. So what's been explained to me, this immunotherapy, it can keep working even after the fact. And we're hoping it keeps working as long as possible. Because immunotherapy, I'm don't want my organs to fail. I realized when it happened how horrible it was, and it's like something I don't want to go through. Being on dialysis for the year I was on it, was I still worked, and I didn't think I missed 2 days the whole year of work. So it was something I really had to. It was really hard on my body and hard on me, but I did it and got through it just to get to the end line, which was the transplant. A couple other things just to throw in there. I have gone through, so I had the 8 weeks of radiation. Then I got, when they did one of my scans, they found my T4 in my spine had a cancer in it. So we did stereotactic radiation on that in September of 24. And then in February 25, my L3, so my lower spine, had cancer in it. So we did more stereotactic radiation on it. And then pretty much I had the radiation from this year, April 7th through April 21st, had 10 doses in the base of my skull. And so they pretty much shot my face, not shot it, but, that's where it seemed like it was concentrated on. But through all that, and my weakest points and everything else, I kept going. And so I'm here today with, 0 DNA cancer. I'm still considered stage 4 from what I'm told, from Dr. Hall's team, just because it's not a curable cancer. It's just something that we're going to keep at bay as long as possible. So between Dr. Hall, Dr. Blosser, Dr. Marciano, Andrea Michelle Purdue, Kristen Province, Dr. Lowe in the radiation department, Dr. Hansen, dermatologist, Dr. Rubenstein, because I forgot to tell you, I'm deaf in one ear after that, after the surgery. So he's been working on that. We've got a tube put in there, and hearing's gotten about 10, 15%, maybe 20. And then Dr. Amin, who, when I was in the hospital, after Dr. Marciano's surgery, he actually pretty much, I give a lot of people credit for saving my life, Dr. Blosser, Dr. Hall, Dr. Mooney, but he literally, my head and shoulders swelled up. I mean, I could barely breathe. I had so much pain. He brought a pair of surgical scissors in and poked a hole in my neck, big gush of blood, instant relief, freaked out my wife. Not used to seeing that, but basically I had a clot in one of the drain tubes that clotted. And so, yeah, been through a little bit here and there. So that's pretty much my story, from getting diabetes at age 9 to cancer, 4 years ago now. And so it's been a uphill battle, but one that we're kind of over the hill a little bit, and hopefully keep coasting, So
Thank you so much, Austin, for sharing all of that. Your journey has been including many different views on life, and the opportunity for you to share that with all of us is really valuable. Thank you. I'd like to move now, having heard your experience, to share a bit about why we established the clinic. And then at the end, after Dr. Hall and I have spoken for a bit, take questions for all three of us, if that's all right. So what I'm going to do is share my slides again. And just to make sure we're all on the same page, Austin got a kidney and a pancreas transplant years ago because of his diabetes. And that rejection he experienced was of both of his pancreas and his kidney organs. Thankfully, those are both doing well. And so you continue to be able to achieve really good function of the transplant while overcoming the cancer as well as you have with a lot of help. And I think you've acknowledged your family so many times. And I just want to also say that without them, of course, we would be having a different conversation. So thanks to your family for sure. Why don't we think a bit about the general concept around cancer in the setting of transplant? Because of a variety of things, people who receive organ transplants are at least twofold higher risk for cancers in general. So that means that over the course of about 15 years after a transplant, at least 10% of people will develop some type of cancer. Certain cancers are higher risk than others. And the most common cancers include skin cancers, like the ones that Austin has experienced, along with lymphoma or kidney cancer. The most common cancers in the general population are also a bit higher risk, but not as much as the skin cancer or lymphoma or kidney, such as lung, colorectal, breast cancers. Those are something that we continue to watch for as well. I recognize that as a doctor, it's one thing to watch for those things. It's another to live with it. And a recent survey of many transplant recipients found that the biggest concern that transplant recipients have about the use of their immunosuppression is their potential development of skin cancer, the number one concern. And not far down that list then is other cancer. So that we definitely have the need to focus on minimizing these risks and then addressing where we can. There are certain risks of cancer that we know. As we get older, our immune system can't identify and fight the cancer as well. Certain chronic conditions like diabetes or kidney disease, as well as tobacco use, all increase the risk of different cancers. Someone who's had a cancer before transplant is at a higher risk for cancer after transplant. And certain immunosuppression medicines increase or decrease the risk of cancer to some extent. But most of the risk is the cumulative or ongoing exposure to immunosuppression. There are certain viruses that actually can cause those cells that are infected with the virus to develop into cancer. Hepatitis B and hepatitis C can lead to liver cancer. Epstein-Barr virus can cause mono, which is common in adolescents, but then can also lead to lymphoma, especially in someone who's immunosuppressed. And human papillomavirus, HPV, can cause a variety of types of cancer, all of which need to be watched for. But there's a lot of risks that we don't yet fully understand, and that includes in people who are living in underrepresented minority groups, along with others that we just need to further identify and address. And that's part of the reason we do the work that we do. One of the most important aspects of care when it comes to cancer care, no matter who we are, is cancer screening. And just like the general population, people who have a transplant should be following the general advice about breast cancer, cervical cancer, colorectal cancer, and lung cancer screening. So really the same for everybody. One thing I would highlight for colorectal cancer is that we're seeing younger people being diagnosed with colorectal cancer now compared to the past. So now the advice is to start screening at age 45. The other thing I would highlight for transplant recipients is that because of the location that colorectal cancer develops more often on the right side of the colon, that's the part farthest away from where the scope can enter. Really requires that a colonoscopy be the standard of screening instead of the other types of screening options out there, like the test with the card or the shorter flexible sigmoidoscopy. It's uncomfortable, but it can make the difference in terms of identifying a cancer early and being able to treat it well. The other that comes back to our conversation with Austin is that skin cancer is a much higher risk. And so continuing annual skin cancer screening, either with a primary doctor or a dermatologist, is really important. There are high-risk populations of people, including if we have a family history of a certain type of cancer, something that we surely need to think about in ongoing assessment with transplantation, as well as the virus-associated concerns I mentioned earlier. I think there are a number of things that we should celebrate in the course of the years of continued knowledge growth. Over the last 30 years, cancer care and cancer screening for the general population has continued to improve. And so I was curious whether or not the improvement in cancer care in the general population has also improved cancer outcomes in the transplant population. So I did this research with Eric Engels from the National Cancer Institute a few years ago, where we asked whether the number of people developing a cancer and their outcomes after a kidney transplant were different over the last 30 years. And across 100 plus thousand kidney transplant recipients, we actually found that unfortunately, there has not been a marked change in the number of people developing cancer. Of the 7 most common types of cancer, only prostate has decreased. And when people develop a cancer, there unfortunately hasn't been a marked improvement in outcomes except for lymphoma. Thankfully, lymphoma has improved, but it's highlighted that we have a lot of work to understand why are transplant recipients different than the general population? How can we do better screening and then better treatment when they develop those cancers? I like to go back to the basics whenever possible, and that includes understanding how the immune system can identify a cancer and how it responds. So if things are normally functioning, a skin cancer like in this picture would release certain proteins, and parts of the immune system, cells like the dendritic cell, would pick up those proteins and travel back to a nearby lymph node, kind of the interstate of the immune system. In that lymph node, those proteins would be presented to other cells like T cells that really help fight cancer and infection and wake up those T cells and send a signal to then have those T cells travel back to where the tumor is and attack the tumor. That works well in the general situation. When immunosuppression is added to that situation, all of those functions are diminished so that there's decreased number and function of those cells that present proteins, so there's less surveillance activity. There's also less activity by the T cells when they're stimulated to do something, and so there's less response against a cancer. And finally, there are also other cells that intentionally put the brake on the immune system, called T regulatory cells or regulatory cells in general. And those actually increase in number so that there's an anti-tumor response to a lesser extent. And so cancer can develop to a greater extent. So immunosuppression is definitely important for all transplant recipients because of the risk of rejection. And we try to target different parts of the immune system in ways that minimize the toxicity or the side effects. But we still need to suppress part of the immune system enough that it won't attack the organ transplants. As Austin mentioned a little bit ago, the advent of immunotherapy is the idea of waking up the immune system to go attack the cancer. And that works really well in a lot of patients in the general population. Unfortunately, the majority of the immunotherapies are intentionally targeting the T cells. T cells are the main part of the immune system that we have to suppress to prevent rejection. And so that inherent conflict is what Austin has lived through of deciding, do we use immunotherapy for an advanced cancer, knowing that the risk of rejection then is 30 to 40% of the time. And if it's going to happen, it typically will happen in the first 2 months after starting, just like Austin experienced. That leads to some difficult choices. And so because of those difficult choices being something that no one of us should have to decide on our own, and the more knowledge we can have to make those decisions well, the better we can be. That led me 5 years ago to start the Center for Innovations in Cancer and Transplant. And with the help of many excellent advisors and advocates for our work, we then set out a vision, mission, and goals. And our mission is to transform lives through integrated healthcare and research for people with cancer and organ transplant. And that includes providing outstanding multidisciplinary clinical care and leading exceptional patient-focused research. And you'll notice that patients really are at the hub of this work. So when I organized our center, I wanted to make sure that patients were heard and focused on in the process of all of what we do. So we've included a scientific advisory committee, people who are experts in different complementary areas of research, and separate but integrated with a community engagement committee made up of multiple patients who can give us advice on the work we're doing and then share it out with the community together. I can't do this work alone. And so a number of people I've pictured here that are really important to this, including Lynn Rose, who's the current chair of our scientific advisory committee, and Glenda Roberts, who's been the chair of our community engagement committee. Felicia Chi is our research coordinator and has done a great job of continuing to do this work with me. Here are our current scientific advisory and community engagement committee members. And I really do appreciate the value that each bring to the work we do, including perspectives that complement my perspective and each other's. Because of how this is ongoing learning, I knew that we needed to build in a clinic in order to directly provide care while hopefully learning and integrating that knowledge back to the clinic as quickly as possible. So at the same time that I established the research center, I approached the Fred Hutch, chief medical officer, and I said, would you be open to supporting a clinic that would be unique for people who have cancer before and after organ transplant? And thankfully, the answer was a really resounding yes. I've been very appreciative of the support that the Hutch has given me and our development and ongoing work of this. And so the Cancer and Organ Transplant Clinic is the first of its kind multidisciplinary consult clinic for people who have cancer before an anticipated transplant or after an organ transplant. And then the questions that we really often address are, what are the appropriate treatments for cancer to help someone get safely to a transplant? And how long do they need to wait to be safe for that transplant, knowing they're going to be on immunosuppression? And if someone develops a cancer after a transplant, what is the best treatment plan in order for that person to thrive? And that includes what Austin mentioned earlier of listening to what that person's goals are and focusing on achieving those goals together. So I built out the structure of the clinic so that the patient would see the appropriate cancer doctor and the appropriate transplant doctor in the same clinic. And then after each doctor has seen each patient, then we have a tumor board conversation where we listen to each other's recommendations, we integrate that knowledge, and we bring it back to the patient and their caregivers in the same clinic time. We record that conversation with recommendations on a flash drive that the patient can take home and listen to, knowing that it's sometimes hard to remember all the details in the midst of a stressful clinic visit. We also share the recommendations back to the referring doctors and want to partner with them in ongoing consultative support whenever necessary and helpful. So over the last 4+ years, we've continued to grow our clinic. We started it in September of 2021, up through the second quarter of this year, meaning June. We have seen 68 unique patients and ongoing follow-up for some of them. Patients not only from Washington State, but from around the country, who we then see. Dr. Hall and I both have medical licenses in multiple states that cover Washington, Alaska, Wyoming, Montana, Idaho. And so it allows us to continue to follow those people either online or in person. And sometimes people will find us from another part of the country and come to us for unique care. Here are some of the people that I get to work with in the clinic, depending on the cancer type and or the transplant condition. And so we personalize the clinic to make the best use of this situation for a high-risk situation. And then we continue to follow along at that point about what someone may need. We've also been able to add nephrology care, kidney care for people who have kidney problems in the setting of other cancer types, so that Dr. Malik, one of my partners, continues to provide that care now at the Fred Hutch as well. One of the people I've really appreciated working with often, including for Austin's care, is Evan Hall, who's a medical oncologist with specialty in skin cancers and kidney cancer. He works at the UW and the Fred Hutch. And I've invited him to give his perspective on how the clinic has been working and what unique experience it is compared to other parts of his work. So Evan, I'll give you the floor for a minute or more.
Thanks, Chris. Thank you for the invitation to speak today, and it was inspiring to hear Austin's story. I think I've been a part of it over time, but something about hearing it all at once, it really just highlights how complex, how many ups and downs there've been. And Austin, thank you for sharing that with us today. It's a lot. It's probably several lives of medical care in a very compressed time so it's really just highlights how intense the care of these patients can be. As I was thinking about this presentation, I kind of fell into this thinking of there's kind of a medical side of participating in this clinic and this initiative, and then there's the patient-facing side. And I think that this is really unique and important in multiple dimensions. Starting with kind of the patient side, I think one of the things I've noticed, and even before this clinic existed, when I would see someone in Austin's situation who'd had a transplant and then developed cancer, is these patients they're different. Patients have already faced a life-threatening illness that led them to get an organ transplant or to be considered for one, or has resulted in the need for something like dialysis. And so I just noticed early on that seeing patients who were then diagnosed with cancer felt a little different in the clinic. This wasn't necessarily someone's first experience with serious illness, and they'd often thought about some of life's big picture questions already because of the other medical problem they had. So I found this group of patients to be pretty insightful and pretty clear about what was important to them. So coming back to what Austin shared about his recollection of our initial transplant visit, that's not uncommon that patients in this setting can clearly state their goals in a way that sometimes is a little harder for people that haven't yet experienced these types of medical problems and given it this thought. So the care is really complicated. You just showed a number of people that are involved in the clinic. And every branch of medicine is increasingly sub-specialized. And although I remember the basics of immunosuppression and how people with kidney transplants are managed from medical school and residency, it's not something that we encounter day to day. And honestly, it makes a lot of doctors uncomfortable to see medications like tacrolimus and mycophenolate, things that we don't encounter all the time. And so at a professional level, working in a close partnership with Chris and other organ transplant specialists, it really makes you feel much more comfortable as a physician caring for patients, because you know that you're harnessing the really unique expertise of all the people that are needed to properly care for someone, and not trying to make decisions on your own with imperfect information. So the team-based multi-specialty nature of the clinic makes it really rewarding for me to participate in, and really makes me feel confident that we're delivering the most state-of-the-art, highest quality care to every patient, because we have that unique structure and expertise. I think the other thing that comes to mind is that although your graphic highlighted the new patients, these are ongoing issues. So both the transplant management and the cancer management is dynamic. Austin highlighted how we kind of went through multiple different cancer treatments with medicine in a rapid fire succession because things weren't going well. And the same sort of thing happens with transplant, and the medicines are being adjusted and fine-tuned routinely. So each of these things is not static, they're very dynamic. And so having not only a forum where patients can have an initial plan, but a forum where these plans are revisited and revised is incredibly valuable, and a really strong open communication between the different doctors that are involved in the key aspects of this care. So I think that that's another way where it's fairly unique and uniquely suited to match the challenges and needs of this patient group. I also find, that patients who've had organ transplants, they have a very strong relationship with the physician already. And for many people who haven't, they end up seeing their oncologist a lot. Their oncologist kind of becomes their the doctor they probably see more than anyone else. And one of the things that I've noticed and value is that our patients who've been dealing with organ dysfunction and then had a transplant have a second doctor who they really trust. They've developed a really strong continuity relationship with. And it's become clear to me how important it is to keep them involved in the care and up to speed about what's going on. So there's just lots of ways in which, and I'm not sure I would have predicted all of these at the onset of the clinic, but there are lots of unique subtleties about caring for people in this situation that are different than just kind of routine oncology care. And in many ways, they're really rewarding. And I think that the organ transplant clinic highlights the importance of multidisciplinary care. The last thing I'll highlight is the research aspect. So it's really hard to see patients in this setting in the diseases I treat, where the main way we treat cancer is immunotherapy. And we have, studies in melanoma and even in squamous cell skin cancer that show how well immunotherapies work that are several hundred patients. And there are exactly 0 patients with organ transplants represented among those studies because those patients weren't allowed in the original trials of these drugs because of the potential, what was anticipated to be a very high risk of toxicity. But because we have an active research initiative, we've been able to learn and start to formulate our own ideas about how to safely administer immunotherapy and try to thread this remarkable needle where we can try to get the immune system to attack a patient's cancer and to try to leave their transplant alone, or at least to intervene early if the immune system starts to impact the transplant. And I think really only by studying a group of patients systematically with a research-minded lens do we move things forward for the next patient. Each patient we do our best to take care of in the moment, but there's something bigger that happens when we compile those experiences together, study the outcomes, and learn how to improve care for the next patient. So those are just a few of the things I wrote down and rolled upon as we were getting ready for today.
Thank you so much, Evan. You said it so eloquently, and I definitely appreciate and have benefited from working with you and the others in the clinic and also with the research. And so with that in mind, I'd like to finish with a few thoughts related to the research that we do and how I've wanted to, from the outset, integrate the work in ways that ensure that what we are doing in the clinic overlaps with our research center and our research questions. And so as we built out the clinic and the research center at the very beginning, I knew that I wanted to establish a registry of patients and candidates transplant candidates and transplant recipients who have had cancer in order for us to answer questions now and into the long-term future. And so this is the only patient-level registry that I know of for those who have had cancer before and after transplant. And we're focused on 3 dimensions of research. The first being patient-related, patient-reported outcomes, surveys of patient experience in the setting of cancer and transplant. Separately, we do epidemiology research with big data and leveraging different data sets, including our registry, as well as other population registries to study the questions at hand. And in addition to that, we also are studying translational research questions, meaning the biology that helps or causes cancer and how we can treat or prevent where possible. The registry has been growing over the last 2.5 years now, and we now have over 570 people in the registry. About a third have had some type of cancer, and we want to continue to encourage any person who is either a candidate for a transplant or a recipient with or without cancer to enroll. We follow their data every 6 months, updating that data to allow us to then use this data for various research questions. And of course, recognizing that the data is valuable and we want to ensure that every person who commits to it in terms of being an individual participating is acknowledged in ways that are appropriate for the work we're doing. This work is intended to be a registry where people can add data, investigators can add data from other sites after permission, and we can also share de-identified data with investigators from around the country so they can also use and benefit from the work together. Our work is intended to be integrated so that the work you do in one area informs the other areas and vice versa, so we can continue to grow together and focus on the biggest questions. And at this time, our biggest concerns and questions are related to the most common cancers, like skin cancer, kidney cancer, lymphoma, and how we can understand the immunotherapy, its effects, and potential benefits on patients who already have a transplant. While we're doing that, we want to help the next generation, those people that are going to be here talking in 10, 20 years about the points that we're discussing maybe, or some other related aspect of healthcare. And so I've really enjoyed mentoring and teaching and being taught from people at various points along the training process, from undergraduates through now medical students like Alyssa Ong, who's in her second year of med school and has been working with me for actually quite a few years. Regina Say, who just graduated from med school here and is now a surgery resident at OHSU, and other team members who continue to help us grow the work that we're doing in the registry and specific projects. And so just to finish in a summary, before we take questions, we know that there's a higher risk of cancer in the setting of immunosuppression after transplant, that certain immunotherapies offer a potential for improved survival, but also a risk of rejection. And that's where this clinic can be very helpful. Pre-treatment patient-centered plan is really valuable, where we talk about what are the goals of life and then proceed and adjust as we go together. Like Dr. Hall said, our clinic is intended to be not just a one-time stop, but an ongoing support for people wherever they live, whether it's in the Seattle area or far beyond. If we're going to deal with a side effect in the setting of immunotherapy, it's more often in the first 2 months after starting the treatment. And so we're very attentive and we'll do a lot of testing to follow and identify any potential kidney injury or a rejection or other side effects in that period of time. And integrating our clinical care and research is critical to improving people's lives now and going into the next chapter. And so I recognize that none of this could be done alone. I really appreciate patients who are willing to be vulnerable and share their experience with me with the goal of helping them. The transplant team, as well as the cancer and organ transplant team at the Fred Hutch, the research teams, everybody has participated in various ways that are really important for what we're doing. And the support that we get from foundations, the NIH, as well as individual donors has been valuable for us to achieve our goals together and going into the future. So at this point, I think we'll stop sharing the slides and take questions that people may have for Austin or Dr. Hall or myself. Thank you for being here. Feel free to unmute or put your hand up and we'll field your question.
Hi, Dr. Blosser. How are you?
Hi, Carla. Good.
Good. Well, congratulations, first of all. This is a
Thank
lot
you.
of work.
Thank you.
My question was for the registry. I understood that only patients with a transplant or with cancer could register, or anybody could register.
We're interested in enrolling anybody who is either being evaluated for a transplant or have a transplant.
Okay.
They do not need to have cancer in order to enroll, and we will continue to follow every person over time, not only to see whether or not they might develop cancer. I don't wish for that, but we want to identify potential risks and then outcomes when anybody experiences some kind of a health change.
Okay, thank you. So I will be enrolling.
Great, thank you.
Thank you.
I have kind of a general question. And first of all, thank you, Austin, for sharing your story. Your resilience is inspiring. My question is, with the research that you're doing regarding immunosuppressants and cancer treatment, knowing that, funding is needed, and maybe in some ways, if there are certain grants that are being applied for that are thinking maybe this is too limited scope, for example, it impacts suffering. It impacts too few people in the general population. And so my question is, with the research that you're doing, can this also be applied to people who are on immunosuppressants for reasons other than transplantation? So autoimmune disorders, for example, could this be reaching a broader population?
Absolutely,
I'm going to mute
Maureen.
myself so you don't have to hear my dogs.
Thank you for asking. I will first acknowledge that the work we're doing in number is small, but every single person matters. Every patient matters. And what we're learning can and is going to be applied, is being applied to other populations, including those on immunosuppression for other reasons, including autoimmune conditions. it's not uncommon for these medicines to be used in transplant situations, such as graft versus host disease after a stem cell transplant. And so leveraging the knowledge we gain can help those investigators and therefore patients in a much broader way. I would also suggest that what we learn in caring for people who have a cancer after a transplant, especially with immunotherapy, can help us understand how the fundamental biology of our bodies works when it's normal versus not normal. And being able to compare normal and not normal has been one of the most invaluable ways to learn the fundamentals of our bodies over time, so that the work we're doing can be contrasted with what happens when we study someone not on immunosuppression, not with an organ transplant. And then by doing deeper dives into those details, identify what's different about that person on immunosuppression that makes it harder or potentially better in a certain treatment way. So we can then add knowledge over time.
Thank you.
Any other questions before we close for the day?
I was just going to make a comment. First of all, Austin, thank you so much for sharing. It's incredible. This makes me cry thinking about what you've gone through in your life. But I wanted to kind of address that question about the small number, and maybe it's difficult to get funding. And I was recently made aware of some statistics that there are a lot of people living with a transplant. And so it's not just the small number that are going through these crises now, but the keeping everybody going for a long time. And so that's a much bigger number. And I think stressing that and keeping it safe and available might help with the funding.
Thank you, Lynn. That's a
Sure.
really good point. And I guess I would also say two more things about the funding condition and the way we can do best science together in the situation where there's few people at a certain location. We need to work together across multiple sites. And so I'm very much interested in partnering with researchers and clinicians around the country and even beyond the US for this work. And that's why I built the registry as I did, so that it can be scaled up and data can be added from other sites. Additionally, support of people like you and your connections to others who would be interested in supporting our work or know of a funder who would be interested in working with us to do really high impact research and clinical care is always welcome and appreciated. So feel free as you sit around the Thanksgiving table to mention our conversation. And if there's an opportunity, we'd welcome your support. All right. Well, Austin, Evan, thank you very much for your time and your thoughts. And I look forward to our next webinar. We're planning on having our next Life Lessons webinar in January, so anticipate receiving those updates or seeing them online. And ongoing, we'll have patient and investigators speaking on different topics relevant to our work every 3 months or so. Thank you again for participating in this. I look forward to connecting with you in the future, and happy Thanksgiving. Take care.